So pass back to Angie or Regina. If you're talking, you're muted.
Yeah, that's not my slide, but I'll go ahead and do it. I think Oscar already mentioned that put your name in the chat and your organization in the chat. If you hadn't done that already, go ahead and do that. Just some quick reminders to press escape to exit the full screen. And if you want to change your view options, kind of hover over that top right to change that. Keep yourself on mute unless you have something, that you want to say, or raise your hand, put it in the chat, and use your cameras if you feel like it. We do understand if you don't. We want to interact with you during the chat and now and be interactive, like Oscar said, and also during our upcoming breakout sessions that we had. But certainly use the chat, and we'll try to answer them as you do. And just a reminder that we are recording the meeting, and it will be available to view along with other toolkit items. And I don't know who has the next slide. And Jamie, you're on mute.
Yeah, thanks, Angie. I think AJ is going to walk us through learning objectives. Morning, AJ.
Hello, top of the morning, everyone. All right. So, as far as our learning objectives today we want to be able to describe the current state related to linkage to care at the subrecipient levels. Learn how to review stigma and how it's perpetrated and when ways people experience it. Discuss case studies, and Oscar mentioned being interactive with each other. So let's discuss case studies related to stigma and how stigma affects our clients and linkage to care in our service delivery area. We also want to be able to observe different problem-solving skills utilized by staff involved in these case studies and participate in peer learning to foster a medical neighborhood.
All right.
As far as our tool, is it me? It's still me, right? Our participant toolkit, um, of course, we have our presentation slides, the Stigma language guide, lens activity, and then the Stigma case study scenarios.
Thanks, AJ. So, so you've seen that there's some different stuff around stigma today, and we wanted to kind of land that plane and bring it home, right? Why might we be thinking about during this webinar the intersection of stigma, excuse me, y'all, as it relates to linkage to care? So for some, it's obvious. And then also for others, the topic of stigma can seem very nebulous, can seem very big. It's like an onion with a lot of different layers to peel. And sometimes it's important to, have the words to call it and acknowledge it, and then believe in our synergy and our collective diversity in order to come up with some solutions, ways to mitigate, ways to reduce stigma. And then we're also super lucky that Dallas County has put some FTE, put some money behind the words, put a wonderful, talented human being in that position to help us address stigma, because we can't end the epidemic. We're not going to be successful with linkage to care. It's not just about medication and access. It's also things related to stigma that are going to make a difference. So this slide kind of helps us break into why we're going to focus on stigma through some interactive activities as well as through our case study breakouts. So this is a reflection of y'all, and during root cause analysis, your RCA, early on in your QI project, as well as throughout the quarterly PDSA Plan, Do, Study, Act submissions, we've had some agencies explicitly call out stigma and name stigma as specific barriers for linkage to care. So we see that representation with those 7 folks. Again, and this crosses our Ryan White funding, our EHE funding. It applies with the status neutral lens and so much more. So our AHF family, Cali Resource Center, Legacy, Prism, we have Abounding Prosperity and SBPAN, right? Even folks who are clinical or support service agencies, we've seen them call out stigma as a specific or a set of barriers. We also know that sometimes it's not that you're explicitly talking about stigma, but a little bit more implicitly or indirectly. And we've also seen that show up with ASD. So it's not to say that not everybody acknowledges it, but we wanted to really call attention and share with you, we're reading what you send us. We're wanting to provide the best customer service and real opportunities as we think about implementing this regional QI project to address something that 8 of our 9 unique subrecipients have said, hey, we know this is part of the experience for folks coming through our doors that we're serving. So I want to introduce Cabria, who folks maybe know and have met and have worked with. We've been blessed to have Cabria part of our ECC team meetings and so much more. So Cabria, why don't you take us through the next set of this webinar? Thanks, friend.
Can y'all hear me?
Yes. Good morning.
Good morning, everyone. It's so great to see y'all's faces again, some that I have met in person and continue to work with. So thank you, CQM, also for allowing me to be a part of y'all's webinar today. And I hope to really take some of the things that you all are working with your QIP and Linkage to Care project and tie it back to Stigma in order to give you all some background information and provide additional tools. So first, we'll start off with the definition of stigma, which relates to the negative attitudes and beliefs and discrimination directed towards individuals or groups. We also want to emphasize that stigma reduces an individual down to a group or one singular undesirable trait. In this case, it could be their sexuality or living with HIV. It's also important to note that because of these negative attitudes and beliefs and also discrimination, the person or group of people can be seen as socially unacceptable. Next slide. These are the levels of stigma. Now, this diagram closely is related to substance use treatment, but also is closely related to all of the things, right? So especially HIV stigma. This goes from a macro to a micro level. So that means macro is in the continuum as things such as policies and regulation, all the way down to provider-based stigma and places where people receive care. And then the next step would be personal or interpersonal, and sometimes referred to as internal. And then, of course, those levels of stigma have certain impacts. So whether it be barriers like we feel in Texas often, expansion to insurance or additional care. The next step on the meso level is having those providers have a certain perception of what service delivery looks like. And then the next level, people having a disconnection to their care and making sure that individuals closely align with receiving care and also supporting others as well. Next slide. So then we get into the topic of conversation of what perpetuates stigma. We've talked about the levels, so what propels that forward? And the two main factors really are myths and fear. So we have myths, which is, sorry, I'm just going to turn on this light over here.
We can still see you well. Nothing like eco-friendly lights to go off during the webinar.
Sorry.
You're
I
good.
like to be a little nighttime owl in here. So we have myths and fear. So myths is basically the lack of knowledge and misinformation. We saw that run rampant the last couple of years, especially with COVID. And it also ties into HIV in the care continuum, because there are a lot of myths that still exist, especially I know in my mom's generation, she still doesn't really understand what I do and how she could protect herself in general. And so just making sure we keep people educated on that as well, which that lack of knowledge and information leads to fear. And fear can also lead to a variety of things, such as avoidance and mistreatment, and also othering, which is a big thing within the HIV space. The next thing that perpetuates stigma is our deeply rooted societal norms. And that goes with a lot of things. If we don't actively turn against some of the things that could be harmful to others in society, or maybe we don't even recognize that these are societal norms, taking that step back and making sure we unlearn things that maybe we've been taught or that society teaches us will definitely make a step towards combating stigma and effectively reaching others. And then the next, as we all know, is medical mistrust. That coincides with the first three, honestly. Whether that be, we have family members that have had maybe a terrible experience with medical providers, or that we are just fearful of going to the doctor. That's something that we need to dismantle and learn to work with our lenses on society, which leads into the conversation of experience. So next slide.
Mhm.
So, just putting a name and defining the ways that people can experience stigma is extremely helpful in going on this journey of identifying stigma and really recognizing what it means within our organizations, right? And so I have a few definitions here, and we'll go through these, and these will lend to another activity that we'll do after this. So, the first definition is enacted stigma. So that's someone's real experience of being discriminated against. And I have a few examples on the slides as well. So, for example, we've heard this a lot before, especially working with community where their primary care provider is hesitant to even provide context on HIV or get into that conversation with those living with HIV. And so that's an actual example of actions being displayed and stigma really existing within those actions. The next one is internalized stigma. That's more of an interpersonal thing. And so that's someone that experiences stigma, whether it be on the prevention side or whether it be on the care side as well. I've heard several different instances where people are, afraid of even getting into PrEP care due to some of the backlash that they could receive. So that example of, feeling that you don't deserve or you don't deserve partnership because of your status is a real example of ways that people can have internalized thoughts and feelings about one's own self after an HIV diagnosis. Next slide.
Cabria, this made me think of something as well where internalized and enacted can overlap. So when thinking about women who want to have a baby and they're individuals living with HIV, there's layers of enacted where they have discrimination or stigma. Their provider limits what they think is possible or reduces their options when it comes to childbirth or carrying a baby. And then there's also the elements of what they maybe think and feel internally as well. So we can see with that example even how, more than one thing can exist at the same time.
Absolutely. And then the next one is anticipated stigma. So that's just the prerequisite, right? So the fear of being judged or discriminated against. So our example here is someone thinking to or expecting to be treated a certain way or avoiding a community due to feeling stigmatized. So that could be interpersonal relationships, such as, some folks within the community are hesitant to share their experience and their status, even though, the topic of conversation comes up often, but they're expected to be treated a certain way due to their HIV status. And then that leads also to another form of stigma, which is the associative stigma as well. So that extends to one's networks or such as a partner, such as even those working in the field as well. So our example here, your partner experiences stigma due to your status. And so now we've summed up all of the different ways that we can experience stigma, and there might be others, which I'm always open to that conversation. And so now that I give you some basic definitions, we can use those to transition into our lenses activity.
Yeah, I'll do just like a quick pause here. Are there other examples that folks have thought of? I see Michael has put in the chat an example of enacted stigma is that weaponization. Thank God you are in care here because other people don't care about you and you would have died without this. I don't know, Michael, if you want to speak to that comment anymore, or if any others have examples of the different various forms of stigma.
I'd love to hear other people's examples. As a person living with HIV for more than half my life, this is one of the most common things that we come across. I think a lot of people who message this aren't aware of what they're saying and the extreme harm that they're causing the people that they serve. It takes maturity, openness, and professionalism to be able to hear feedback that what you're doing might be causing harm. I think a lot of us then shield ourselves and say, screw you. Who are you to tell me that I'm causing this harm? But baby, you got to be open, mature, and professional to hear that stuff, especially if you're not actually part of the community. The things that you think are helpful may be very harmful. What are other people's experiences?
So, Michael, I think that so I was a case manager for a long time back in New York, and I can see how easily, whether we're case managers or peer navigators or CHWs, how we can get into that territory of us making clients feel like they owe us, right? And that's very real, and I've seen it happen. So some other reason why, we need to check ourselves, right, before wreck ourselves and know that it's all about the clients. We're just there as a tool to make sure that we provide the services or we help and coordinate other resources and benefits. And then, and thanks so much, Cabria, for the presentation thus far. Is stigma like any other, let's say challenge? It needs to be broken down, right? Because it's on itself, it doesn't mean anything. It's what leads to stigma. So I am appreciative of how you're really breaking it down for us to really understand what causes stigma. And it doesn't happen in vacuum, right? Different elements and factors that contribute to stigma itself. So thank you so much.
Yeah, and I definitely want to take this time, honestly, to emphasize the breakdown. Stigma can be hard because it's so deeply rooted, it can be hard to recognize. And so we need to work on challenging ourselves and our bias. And thank you for that comment, Octavio, as well. And thank you, Michael and Jamie, for the support. So as we lead into this next activity, I really want you all to think about your lenses, right? So this is an activity. My team here has gone through several NMAC trainings. One, honestly, was the basis of providing context for the FTE and allowing me to be here with you all. And that is the Escalate Learning Collaborative. This activity was taken from the Escalate training that is focused in ending stigma. And so, next slide, Jamie. So we'll be exploring some of our lenses. And our lenses basically are tied to our identities, which helps shape our world around us, right? So our perception is also shaped by our culture and our experience. And these are just a few examples of some lenses. These are not all, but I can give you all an example of my lenses and how I view the world, right? So I am a Black African American cis woman. I grew up lower middle class. I'm spiritual. I know the Lord, but going on that own journey, going on one's own journey. So I'm spiritual. I'm 25, which is, on the younger end, but that can also lend to some conversation. I'm American. I have a bachelor's degree. I was raised by a single mother. Family dynamics are always something interesting. And then my last one, I'm heterosexual. So really with this activity, we hope that you all can identify some of these lenses and really foster additional conversations on how you view the world. And so I'll give y'all some instructions on the next slide. So we'll do some breakout rooms. We'll have 5 minutes to reflect on our own identities. We want you to make a list of at least 10. So that'll foster some really good conversation if we get at least 10. And you all can use the example that we had on the previous slide, and just really make sure to use this time to identify things that shape your viewpoint, right? Next slide.
Yeah, let's go ahead and I'll put these examples up so people can see it. So, hey, y'all, grab that pen, marker, paper, make a note in your phone, doodle, doodle, doodle on whatever you want to doodle on. But let's take about 5 minutes for everyone here to silently reflect. How would you describe your own lenses? So, Cabria, thank you for sharing yours, A of all. And then B of all, again, here are some examples. There's no right or wrong answer. So however you would say, these are the lenses, these are the components, the kaleidoscope of my identity. I'm going to set a stopwatch. And so we'll take about 5 minutes for folks. Don't think about it too hard, jot them down, and hopefully you can get up to 10. We'll start the clock now. And all Dallas County folks are also participating as well. So, this is an et al. Activity. Michael's got the cutie Post-it. We'll give it about 1 more minute.
Did we say too that for people just to list what they feel comfortable sharing?
Oh, great question.
Nobody has to say their sexual identity or their, whatever that they don't feel comfortable with.
So great question. Yeah, I mean, the note that you make is only to yourself. So, you're welcome to include whatever comes to your mind. And then when we get to the sharing part, no one else is going to know what you wrote down. So you don't have to share beyond that. I think it's still valuable to express to yourself what those lenses are. So I would still encourage you to do that. I have some on my list that I don't want to share with everybody. I'll tell you that much. But they're still part of my lenses. So great question. Thank you for ensuring we be clear about that. Thanks, Angie.
Jamie, I don't have anything to share, but when I first, because as I'm thinking all of these different things in my position view and basically my
Mhm.
lenses, um, when I first heard the term privilege, it took me a little while to really understand privilege, right? Like privilege how? Like is it something that, is it about class, about this and that? And the more I learned about it, is really our position and what's available to us. And sometimes because we earn it, sometimes it's passed down. So to me, it helped with understanding what my privilege is, right? It's not good, it's not bad, it's not just, it's not unjust. It just is. It's part of who I am, it's part of where I'm at, and it's part of basically my immediate environment. So that's what I think when I look at this exercise is that what is my privilege, right, versus somebody else's privilege. And again, it's not about anything other than just that. It is what it is in that term. So that's what I thought about when I started looking at this exercise. Is what is my privilege in the middle of all of this?
Thanks, OP. Privilege is definitely related to stigma and bias, and that's where Cabria is also a rock star to lead us through some of those things. So at this point, we hope everybody has identified some of their different lenses silently to themselves. Cabria, walk us through what we're going to do next, please. Oh, you're muted, dear.
Now y'all can hear me, right?
Yes.
Okay, so we'll go into breakout rooms. There'll be two people per breakout. And you'll share 5 minutes and 5 minutes, to the extent that you're comfortable, right? Your lenses, and then you'll discuss how they impact, your identity, sorry. And then we'll discuss how they impact your lenses or your viewpoint of society. So I guess we'll get into our breakout rooms now.
In Korea, in a group, someone will be taking notes and reporting back, or
Within the group, you all can take notes, um, or you can just have the conversation, and then we'll come back together and we'll share some of the things that we've talked about within the breakout rooms. We'll have some guided questions that will serve as a debrief. And so if you all have your juices flowing, we can talk about some of the things that you all discuss within your breakout. So no need for copious note taking, but if you all want to jot a few things down, I encourage it.
Yeah, so this is a quick pair share. Share whatever you feel comfortable with. This is just you and one other person having a conversation. The breakout groups are randomized. I'm getting ready to open them. And so have fun. We'll see you in about 10 minutes and we'll do a voluntary debrief. So I'm going to open those up. You're welcome to go ahead and select join. And I'm double checking. If anyone ends up by themselves, I'll come back around to fix that. We might have one breakout of 3 people. I had to pause it. Go ahead, Cabria. I dropped
Perfect.
some of the debrief activities into the chat. Thank you, Sandra. I'm glad you thought the pair share was the way to go. So Cabria, do you want to grab maybe a couple of volunteers? We're hearing some positive early feedback, but let's dive a little bit deeper.
Yes, yes, yes. So if we can have 2 or 3 volunteers to come forward and we'll go through some of these questions and continue the conversation. You don't have to share everything that you discuss within your pair share, but definitely little droplets of information that can contribute to the conversation. So anybody want to share first, or do you think we should probably go through the questions and just have people share? So, so this first question, how did it feel to share your lenses with someone else? Anybody want to share?
This is Helen Turner. I found it, I loved it, actually. It was very good because I got to know Jane better.
Ah,
And I got to see that we're both Black and we both have some shared experiences. And I enjoyed the fact that I could say, I'm Black, I'm religious, I'm a mother, I'm a grandmother. I lived with AIDS for 34 years. I'm a survivor. I have a fixed family culture where my family felt family business is family business, only go to doctors when you're sick and never psychiatrists. That was a fixed idea that came forward for positive and negative, but it allowed me to be able to help others, to be a more caring individual, to be able to say, I know the difference between cultural conversation, courageous conversations, and cultural humility and cultural competency. And it's not about me, not my character, but it's about my character, my willingness to bring knowledge without judgment and be able to listen and to be able to help others. I'm a caring individual. I could probably rattle on, but I'll
thank you, Miss Helen.
I'll stop now.
Thank you, Miss Helen.
You were with Jamie, you said? I think
Yes.
you were with Angie.
She was with Angie.
Oh, who was I with? I was with I thought I was with Jamie. Who was I with?
Names are close.
Angie.
I was with Angie.
Correct. Yeah, okay.
Okay. Angie, why don't you share from our experience?
Yeah, sure. Just kudos to everything Ms. Helen said. We found out we have a lot in common. You know, we have a lot in common and a lot of the same things that she listed already. And we had some things that, in our family of origin that were there. And then we also broke away from some of those things to form our own worldview. And I want a calling to help and caring about others and everything she said, I co-sign on. Thank you.
So y'all have gone through and answered the first 3 questions, kind of. So it sounds like you all learned quite a bit about each other and were able to relate. And therefore, that kind of shaped your interaction and your worldview, which is exactly what we want you to get from this conversation and this activity. I also see a few people in the chat, some really good answers about being seen, heard, liberated. Also, Brian was saying your comfortability with sharing your own lenses has a lot to do with self-actualization and realization, which is a great point, Brian. How comfortable we are within ourselves and our own identities comes off in our interactions with other folks. And so the next question, how are we always transparent about our lenses? I think Brian did a good job at getting into that conversation. Is there anyone else that wants to speak up and volunteer about their transparency?
Go ahead, Joni.
I'll go ahead and say something. I was with Dwight, and I really enjoyed the opportunity to get to know him a little better. Dwight and I have been, worked together for the 5 years that he's been with ASD, and it's just interesting to learn more about someone that you think you know a little bit about. And so that brings me to my one transparent piece is being judgmental, having my own experiences kind of lead me to make an opinion before I've given that person or that opportunity or that experience, a chance to sort of resonate with me and form an opinion, not based on my past experiences or what I think or what I feel. And so that is one of the things that we talked about sort of being a work in progress, something that you might know, but maybe easier said than done. And so I'm really trying to work on not allowing my personal experiences to shape my views before I've given someone or something an opportunity to sort of resonate with me in a different way. So I really enjoyed the experience, and it was nice to get to know, like I said, quite a bit more in the small amount of time that we spent together. So love that activity, and thank you.
Thank you. Thank you. Yeah, Joni. And I know some of you are going through the Trauma Informed Care Collaborative, which they speak a lot about, that judgmental piece as well. So all of these things are aligning. And we hope that we can continue to break down some of those deeply learned societal norms and continue to change our perspectives, right? We're never too old to learn a little bit more and get a little bit more context of things. So we'll transition to some questions about this activity. Does anybody have any questions moving forward? I want to thank you all for participating in this great activity, which can also be brought back to your organizations. I'm not sure if we have the lenses activity chunked out, but you can definitely take from this PowerPoint in this webinar as well.
Yeah, thanks, Cabria. We'll have this activity in the toolkit, but one thing I've noticed, and Cabria has also been fabulous about, anytime we talk about stigma and our intersectional identities, we have those moments to reflect on ourselves and our experiences. To Perry's point, we want to also foster a safe and loving space. So we have a very quick, like 3-minute self-care debrief, and then we'll move into the final back half of this webinar. So folks are welcome to close their eyes, turn off their camera. This is a quick activity just to kind of recenter ourselves after sharing some of our vulnerabilities and opinions and experiences, and then we'll move forward. All right, folks. Sorry for the abrupt end. So hopefully we've taken a moment to sort of catch our breath and recenter ourselves. I'm going to start my video back, and we would love to see our EHE, Ryan White, clinical, non-clinical, the full fam on deck. And our next slide, we're going to turn it over to the one and only Angie Jones to share a little bit about the current state of our linkage to care. Oh, timeout. Our linkage to care PDSAs. If I can get this to work. There we go. Okay, folks, see the screen? Yes. All right, Angie, take us away.
All right. Yeah, so just real quickly, just our PDSA for the Ryan White side, the current state right now, we have 6 agencies in the D phase, 2 who are in the A phase. One agency's submission is missing. 2 of our 3 jointly funded agencies are doing separate QIPs from across programs. Because we have, you know, the bubbles represent the focus of QI projects. So those were some common themes that we have going on. Some are focusing on our, you know, bacterial dual diagnosis link in 7 days. Some are confirming care in for new to them, making sure they're confirmed into care. And then a few others are doing other things. And so just a note to great kudos to you all. Many agencies have really moved through their QIP methodology since August. So we're seeing a lot of progress, and thanks for all your hard work. And I'll hand it back to Jamie.
Yeah, 100. And then on the EHE side of the house, again, thank you, EHE fam. Thank you, EHE Dallas County staff, because this has been our first foray as a combined jurisdiction into a regional QIP. So similar to the Ryan White side, you can see what the QI project focus across the 6 EHE funded subrecipients are. We have one agency in the P phase. We have a majority of folks who moved on to the D phase. We definitely treasure getting those quarterly submissions. So if anyone ever has a challenge or needs an extension, we can always work around that and work with you. But I want to really echo, to me, the biggest takeaway when we think about the current state of these PDSAs across both sides of the house is that we have had a lot of progress through the QIP methodology since August. This is the 3rd regional QI project that Dallas County has done in its history of doing it. And we've often sometimes struggled to like make progress through the phases, but you all have been wildly successful with that. So we want to salute you, and we look forward to getting to share more of the outcomes and the results during the World AIDS Day Poster Symposium. But next, I'm going to kick it over to Michael to talk to us. We want to bring you some more case studies. So Michael, I'll hand it over to you, and then just let me know how you would like me to progress your slides.
Yeah, absolutely. This is something that we got such great feedback from you all in terms of more, please. So we're trying to be more person, community, and example-centered to drive our thinking and to really push ourselves to apply the learnings that we have. So we have a couple of case studies that we're going to go through. And like last time, we're going to start with an example. And then we'll have breakouts where we work on specific case studies, and we'll all come back. So let's go to the next slide. We'll share our example scenario. So meet Kenny. Kenny says, the clinic I work for provides a lot of services. I don't get tested there because I'm close to a lot of my coworkers, and they've judged one of our other coworkers about getting treatment. I don't need my health as a topic of conversation. And I'm assuming that ... where I work. So I would, like to see what other people think, but this reminds me of 2 things. One, when I was working at Whitman Walker in DC, people were like, oh yeah, you should go get the free STD testing. Oh, you should go get the free, mental health screening. But then I would hear case managers, nurses, or even medical doctors in the elevator giggling about specific cases that are community cases, or worse yet, giggling about what a colleague said or did, or even what the findings were of their work. And that to me blew my mind. So I don't need my health as a topic of conversation. This is kind of that same idea, like I don't, ask where I eat, and all that kind of stuff. So I just want to see what reactions people have about stigma here. How much stigma is internal stigma or enacted stigma? How much of this is perceived stigma, and how much of this is stigma by association? Any reactions? Any thoughts? I kind of gave you my 411 on it without using the words.
I want to echo that, Michael, because in the clinical setting is a bubble that tend to be very private, quotation mark, because the one who make it private is the provider and the people who follow that provider. And usually there is a lot of conversation behind the curtains that we don't know, that reflect the culture of the clinic itself or that specific provider. When the hospital is pretty large, usually those providers who have a group and there's a 1, 2, 3 judgment allowed, it grows. It grows like cancer. And it is real. It's nothing like just an anecdote that someone may imply. It happens. And it's sad that it's happening because that's supposed to be the main point of non-happening. So I connect with you, and I'm pretty sure that some who are connected with the provider or large clinics or big service providers have seen that elevator poster on Dallas County for HIPAA violation. I noticed, and I made it public, just women are connected in that poster talking about something private and don't violate HIPAA, but then just gender. It's focused and it's targeting someone. I mean, the stigma occurs in a clinical setting more than you can think in the comment about breaking privacy of the patient.
So I see Norma says, methinks this happens a lot. I don't know, Norma, if you have any anecdotes to share or any fears or any kind of conversational currents you want to, kind of mention.
I think it happens a lot. I think that when you hear or see this happening, you kind of need to reacquaint everyone with HIPAA, privacy, confidentiality, and just respect for another person. This should scare, staff people or people who do this should realize that their health stories may be talked about, and you shouldn't do that. It's not right.
That's right. Yeah. So, for me, this is definitely perceived stigma. This is definitely internalized stigma. I mean, this person, Kenny's judging himself, and he's afraid that other people will judge him too, based on, his own experiences. I see Kim, I see Brian. Kim, go ahead.
Yeah, the thing that stands out to me in this is these people work in healthcare. It's not like it's some other place that, oh, someone's coming in and doing the free testing. They should know better than to be talking or gossiping. And I have a friend that kind of had that experience, but with a family member. And even though the family member didn't owe him HIPAA, she worked in healthcare. She knew better. She just happened to be back in the ER when the doctor came and told him his test results. And she immediately went out to the waiting room and told the rest of the family, which means probably rest of the family and anybody else in the waiting room. And that was, fortunately, the rest of the family embraced him and it wasn't that bad, but it just made me so mad that she's in healthcare. She should know better, and she didn't.
Mm-hmm. I love that story. I think, what you're kind of sharing is, it's not apologia, but it's understanding like what maybe some of the processes that drives a person to do what they know better than to do, right?
Yeah.
Like there was something that kind of like So when we think about moral injury and we think about like, it's again, like what Jamie had said, like, it's really easy to judge people, especially when, you know, we've been harmed. And like, I know that I'm like, you know, well, how do we enforce this based on like, you know, Octavio's comment? We do need to think about enforcement, but in a supportive way. Do we all need to be nuns walking around with yardsticks slapping hands? Right?
Yeah.
Brian, go ahead.
All right. So, I'm not sure how many of you are providers at all or nurses. The scenario was pretty cut and dry where the gentleman was talking about uh, people at his clinic talking about a specific person that they identified as working there. That is 100% unacceptable. I don't think anyone will argue that that is wrong and that it should never happen at all. But I can tell you the elevator talk does happen, and it is not necessary, and it sometimes is beneficial. And you see it in a lot of professions that are high stress, that deal with a lot of things. For instance, when I'm retired from the military, when I was in Iraq and we're getting, you know, shot and blown up, the humor that you had about it was just dark. And it was just accepted as, you know, that's just the dark humor that was there when we were there. The other thing is, if you've worked in the ERs, I think someone has mentioned, I mean, it's not uncommon to laugh about the, you know, the third candle in the rectum you had this month because you're kind of stressed out about it. You're not calling out people's names. Is it in a perfect world the best thing that should happen? No. But at some point you need like these little pop-offs. And I'm not saying it's a great thing or a good thing, but I think you have to kind of understand where some of these folks are coming from, especially ER services, especially labor and delivery. I don't know how many of you are nurses that have worked on L&D or physicians that have worked on L&D or in the ER. So I get what everybody's saying, but I do think that there's a time and a place for people to have pop-offs. The elevator probably isn't necessarily the best place, and you definitely shouldn't have any patient identifiers. And like I said, in this particular scenario where, you know, the guy was like, I know that they are talking about XX person that works in this clinic. That is 100% unacceptable. But I kind of do agree that, you know, and I probably wouldn't go somewhere to get my health that I worked, get my healthcare that I worked, if I could avoid it. In the military, you had to go in, you know, so I ran the clinic, but when I go get healthcare, I was seen by people that I oversaw, you know, physicians that I oversaw. And so that can be a little bit of a, you know, makes it difficult sometimes to be completely open with someone that you directly supervise, right? Or someone you have to work with the next day or has to see you, you know. Because when I talked to Jessica, I'm sorry to ramble. When I talked to Jessica, one of our lenses that I had was, I explained to her was, you know, some of the patients we come in, we ask them the standard questions. How many sexual partners have you had? What kind of intercourse have you had? Anal sex, front hole sex, insertive sex. So it can guide our treatment. You know, sometimes I have to really focus, you know, concentrate on my face when the patient comes in and is like, oh, I've had 36 partners in the last 3-4 months. And that's not necessarily uncommon, but it is kind of, you know, kind of shocking. But
So you focused on so many cool things, Brian, like, and I really appreciate that. You know, for those of you involved in trauma-informed care, but I think that the stigma activities that we have ongoing will get there too. You know, I was going to start putting this in chat, but one of the best organizations I've seen do this is a small harm reduction organization in Harlem, and they carve out time for staff to be able to talk about this in a support group setting. I also want to point out, some of you may be aware, some not, that doctors and lawyers have their own AA and NA and stuff like that, so they can express their humanity and try to heal in a way that isn't going to end up causing them to lose their license and their well-being. There are so many different ways that we can think about this in a constructive way to work with people's humanity rather than to always jab at it and shut it down and to judge people. Because judging people for judging people ain't gonna get us nowhere, boo-boo. Octavia, you're next.
Thank you, Michael, and then thank you, Brian, for your comments. So my comments are sort of the same ballpark, so to speak. I think when I think of stigma and in this case conversations in elevators, the first thing I think of is intentionality, right? Are people intentionally talking about or they want to discuss a case just because they want to gossip, right? Or just because they want to do? So it brings me to, does the agency or is there a culture of having the right place to your point, Brian, to discuss cases, right? The elevator is absolutely not the place. But then I think of the reason, and what I put in the chat, it's some hospitals have those signs. I wonder that if probably happened as a result of a lawsuit, right? Someone heard someone's name and therefore then the legal got involved and the hospital sued. So now it's a standard practice now in the elevators for they not to discuss any client's cases, right? So brings me back to what I just mentioned. Does the agency, hospital, clinic have the right setting where these conversations can take place? Case in point, what we're going to today, or might do today, it's the case study, right? Or do they come together, different teams that work with clients and they have a discussion about a client's case, right? It's more productive. It's within a closed environment that is safe where HIPAA will not be violated. So I go back to intentionality. Does the agency have the place and setting to have these conversations? Lastly, I worked many, many years ago where we had a team meeting, staff meeting, one-on-ones. So then at the same time, you can go the opposite way where you have one too many meetings and not enough time to do the work. So again, I go back to intentionality and whether someone wants to intentionally discuss cases, or is it because maybe I don't have the right place to do it? Again, I'm not saying that should happen, but I wonder about, does the agency have the structure to have the place and time to have these conversations?
Yes, yes, yes. Helen, you're next.
Hey, I think in the example that's given today, all of these items, internal, associative, perceived, enacted, I think they all are applicable. I said earlier in the session, I was with Angie, that I personally don't mind stigma. I worked with, for 34 years, I after 34 years, I lived with AIDS for 41 years, be 42 this month. And so I've seen every kind of stigma known to man, but for 34 years, I decided that this kind of thing that's this example is showing is not at all acceptable, and it covers all of these. And you ask yourself the question, and I was asked this question at the Texas HIV Medication Advisory Committee meeting just last Friday. So do you give a break when it's unintentional? Do you give a break when that stigma is coming at you, that's in the elevator or in a circumstance as this one is? And I say, no, you don't give that break. What you do is you educate, you train, you let people know what is expected, and you ensure that they comply with what is expected. Anyway, I'll stop there because I'll get motor mouth here.
Yeah. No, I mean, like, there's a lot to say on it. And I think, hidden within when you're saying, Helen, is the visible and invisible power structures that we have. I think Octavio and Brian both spoke to this, right? Like, what if it's the chief medical officer who's doing the gossiping? What if it is a board member who's doing the gossiping?
Then it's my chance to educate. I don't mind stigma.
Yeah. No,
it's my chance to educate. And They are not excused.
You are a brave soul. I think most people will be like, girl, I don't know if I feel confident yelling at my boss.
Well, if you've lived for 41 years, 42,
God bless you, Miss Helen. I need
you
you
learn.
in my life more. Go ahead, Jamie.
Yeah, I want to thank everybody within the chat and for unmuting and sharing. First of all, it's really there's been a lot of thought behind how do we bring this into our conversation, name it, acknowledge it, and then talk about what do you do, to that point. And having worked in the Escalate program and having had lots of time with Cabria so far, a couple of things to note. One, this is just the beginning of this discussion today. We can expect to have a commitment and a continuation to it. Things that I've found valuable that are part of what we want to offer through Cabria as a dedicated, continuous support is to address like, what do you do when? And not only when you witness it or experience it, but to Michael's point, when there are either named or hidden power dynamics that are also reality, right? There's a lot of intersectionality to all of this. So there's some different ways to go about it. But one of the things that I took, two things as a key takeaway from the Escalate training is to think about whenever, how do you like to be woken up in the morning? So me, I prefer to wake up without my alarm and then snuggle my cute dog and take it slow and steady and like ease into my day. What I'm not all about is that iPhone being like, rah, 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 and then being rushed and all that business. So when we illuminate people to their privilege, to their bias, to unacceptable or stigmatizing behaviors, attitudes, thoughts, and beliefs, how do we want to be woken up, right? So you don't want to like grab them and be like, this is ridiculous, Now there might be a time and place for that, and I'm not going to tell Miss Helen or anyone else how to conduct themselves. I would not want to say that. But for me, what's helpful to calm my own emotions and my disgust or my sadness, one way I can temper that in order to be effective is to think, how do I want to be woken up and how do I wake someone else up to this, right? The second thing that's helpful is keeping in mind like the software of a mind. So whenever I get a new phone, which I hate, and I don't know, Michael, I'm very like laggard with this. I think you got a new phone recently, and I too try to put that off as long as possible because I hate it, right? Whenever there's a software update or when your computer restarts, first of all, it's never good timing, right? It's always frustrating. It's always a pain in the tuchus, okay? Technology software updates. So in some ways, getting a software update of the mind around privilege, stigma, bias, these power dynamics, all of these pieces, right, can be a little bit of a frustrating and unsettling process. So how are we patient with ourselves and how are we patient with others when there's a software of the mind that's getting upgraded and switched? So those are two things that that I think assist when we move toward action, speaking up and speaking out and addressing stigma. But very quickly, I just want to again put another plug in for appreciation. I think we had a baller comment from Nisa representing legal services in the chat that also speaks to how stigma and associative stigma can be outside of clinic doors. So just a real quick nod. So folks here know we have several other case study examples. We have 5. And again, with some love, they even encompass things like access to PrEP, right? Disclosure of status, so many more. These examples come from Belen and some experiences she and her EHE linkage care navigation team have. These experiences also come from work that Cabria has been doing in Dallas. So these 5 experiences represent community that we say we're, part of, committed to, and work for. So these will be included. There's a standalone file in your toolkit. And again, the lenses activity, these kind of case study discussions is something that we would be happy to support and facilitate across your team as it relates to linkage. Dee had included some thought prompts as well. So what might we learn or take away from this? What different type system level changes, agency or even individual level kind of self-reflection like we did with our own lenses that helped us show we have a lot more in common than we realize, or I've known you for so long, but now I feel like I know you, right? Some of those same takeaways can happen. So I want to put that plug in for the toolkit and for our support. And then I'm going to hand it back over, I believe, to Angie to help kind of round us out for the day so that we can be mindful of everyone's time and activities that you have going on. So Angie, why don't you help round us out?
Yeah, we're just going to go through our remaining upcoming dates that we have between now and September. So we're at the end of, we've made it. We're at the end of the road, Boys to Men, I think. So we have, this is our last webinar, and next we have our poster symposium on World AIDS Day. So we want our subrecipients to take this time to use this action period to keep moving through your PDSA and to accomplish your aim statement. We have the template for the posters and stuff and instructions that we'll send out in an email. Next slide, please. Do you want me to do these or you want Dee to do these?
Whoever.
Go ahead, Dee.
Yeah, hey everybody. So December 15th, the PDSA worksheet as well as the QIP metric for Ryan White subs is also due, as well as the quantitative data reports. Coming up here in December, we will be having our QIP poster symposium World AIDS Day event hosted on 12/6/24. There will be more information sent out about that later, but the submission due date for the posters would be 2 weeks prior on 11/18. Thank you, guys. Were there any questions?
I would like to highlight something. Thank you for bringing that up. Just to share with the subrecipient, with all of you, we're gonna be collecting data to the E2. Please, we encourage you. Please report that. Use the system to report to the county, because that's the data that we're gonna reflect back to you. So the low reporting, it reflects like no numbers to count. It's important for us to remember. And those submissions, it's better if you do it during the time, because that gives us a chance to collect the data, analyze, and be able to give back to you what the product is of your efforts. So keep that in mind. But thank you very much for those who've been. If you knew it, remember it. If you didn't, learn it. Thank you. Thank you, Dee.
Yeah, so any questions about between now and December? Thank you, Dee. So 11/18, that's when we would like to receive your World AIDS Day poster. This year, we know we're going to host World AIDS Day at a separate location. They've got some cool digital screens. So we're actually going to digitize the posters. We're going 2024, baby. So we won't have to actually print them. We have the templates. We've kind of designed them internally. We're just waiting for final approvals. They'll be emailed and uploaded to Glass Cubes with instructions. Sangita, is that what you were getting at? Okay, cool. Yeah, so we've zhushed them around, zhushed them up, so that information is coming soon. Any additional comments or questions before we do a quick evaluation poll and close out for this October webinar?
I have a question. Oh, no, go ahead, Jessica, you first.
Sorry, thank you. Yeah, no, I actually had a question. If the boards are digitized, is there a possibility for us to kind of play with like animation or like special effects in that way?
Yes, girl.
Okay, cool.
Cute. Yeah,
You said it.
Hey,
go for
awesome.
it. Very cool. Our digital marketing peeps are like, let me make this happen. No, I'm just kidding.
No, I mean that I think is a really cool question and really awesome. And I hope that folks are able to think about making posters that are super dynamic and engaging. We know that your posters, the printed ones, some of you have been able to find a home for them, but many of you do have TV screens or some type of display also within your waiting room or other areas, your facility. So we would encourage you to use that space if possible and when possible. My question is to the participants on today's call who work at agencies. Who here thinks that they might take one of these two activities lenses or these specific case studies and try them in their agencies within the next 6 weeks. So before World AIDS Day. Show of hands, anyone interested or think that they might try it at their agency? HSNT said yes.
Jessica.
We'd be really interested in your one-on-one calls that'll be coming up to figure out why not. Why wouldn't you want to use something like this at your agency? Because I think we need to push ourselves hard on this. We've pointed out that our meetings can be like a merry-go-round of death, and we are doing this with you because you seem to be resonating for it. So think about your own content, which may also need some life breathed into it that makes it person-centered. So we will be asking you what it would take to have you do these types of activities at your own sites. Thank you.
Thanks, Michael. So we're going to go in. Angie's going to drop the link for this poll into the chat for folks who prefer to take the survey this way. Others, you can grab that little cell phone, hold it up, and scan the QR code. This is a brief survey. Again, it kind of dives at some of what Michael was asking, but we want to make sure these are a value add and that if our aim is to increase linkage to care, if our goals are to end the HIV epidemic, we are taking active, concrete steps toward providing the kind of support, dialogue, difficult dialogues, and so much more into meeting that. So please kindly take this survey. And then as folks complete the survey, we'll definitely wish you a wonderful day. You're welcome to leave, keeping in mind that the storyboard poster template is coming. And the next due date for your quarterly PDSA is December 15th. And for our Ryan White funded agencies, that's when you'll also submit to Glass Cubes your QIP metric around linkage in those focus populations. Oscar, or anyone from Dallas County, some closing words?
Absolutely. My pleasure on that. I want to take the opportunity again to thank you for participating on this and make this happen. We understand that you have different things in your plate and not just Ryan White. I mean, this is one extra move for you, signify extra time, extra effort to be able to count those numbers, send that report. But speak to us. We don't punish anybody. We want to hear your opinion. We want to hear you're getting late. Send us a note. I'll be this time and I'll be reporting that time. We completely understand your situation. And now the RFP is out. Everybody's working towards that. We get it, but please, communication is important. Just tell us and stay tuned with us. We don't looking forward to punish you. We are looking forward to thank you and keep working and doing the good thing for Dallas County and our community, which is our main focus. Thank you so very much again. Thank you to our coaches, Octavio. Thank you for those examples. And yes, we would love to have that conversation about clinical settings and stigma. It happening. Personally, I'm telling you, it does happen and keep happening, and it's not new. Stigma aware at the church. Bring that topic to the church. Stigmata. That is the origin of the word. So it's very delicate to say this one here. Bring it on. I mean, it's always growing in a good way. Again, have a good rest of your day. To EHE people, to ECQM people, my team, your team, our team, this is us. Let's make it happen. Like Piper said on that note, let's make it happen together. Thank you again.
Thank you, Oscar. Thank you, Cabria. Have a wonderful day, y'all. Thank you so much. Great work. See you later.